Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm happy to welcome today to Retina Synthesis Dr. Michael Singer, who is clinical professor of ophthalmology at the University of Texas Health Science Center in San Antonio. And Mike is a well-known clinical investigator in retinal pharmacotherapy, and we're here today to talk about the use of the Fluocinolone Implant in a phase 4 trial, the so-called Paladin trial. So can you tell us a little bit about this, Michael?
Well, Carmen, thank you so much for having me on. I'm excited to be here. The Paladin trial was a prospective 3-year phase 4 study looking at the Fluocinolone Implant in patients with diabetic macular edema. And essentially what it was used to do was to evaluate the incidence of intraocular pressure lowering procedures in patients treated with the implant. And that was the primary endpoint. In terms of secondary endpoints, though, best corrected visual acuity before and after the implant was put in the eye, central subfield thickness changes over time, what was the treatment frequency before and after the implant, and other ocular events not related to intraocular pressure.
So what were the results of the IOP study?
So basically, the IOP study enrolled 202 patients, and essentially enrollment was between May of 2015, and it went for 3 years, and assessments were done day 1, day 7, month 2, 3, and then every 3 months until 3 years. And in addition, there was an amendment so people could get the prospective data retrospectively, looking at what happened before the implant was put in the eye. And essentially, there were 202 eyes, of which entered the study, 94 completed, but the interesting thing is about 35 people had both eyes enrolled, and once one eye hit the primary endpoint, the other eye was discontinued. So the interesting thing is a third of the discontinued was because of the fact that the one eye made it. In terms of adverse events, there was only 2 eyes that were discontinued for that, but people obviously were lost to follow-up. Then, when we look at I'm going to go, before I give you the real answers, I'm going to give you some basic data on this population because it's important to understand this was a different set of population than the previous prospective study that was the FAME trial that got approved for the approval of the medication. All these patients had a steroid challenge, and essentially about 15% of patients were phakic versus a vast majority that were phakic in the FAME trial. And these patients, a third of them were well treated with vision of 20/40 or better, or a CST grade under 300 microns. And in terms of understanding the primary endpoint, although the primary endpoint was the incidence of intraocular pressure procedures, the vision is what we all wanted to know. And it was interesting when we looked at these patients prior to being treated with the implant. Over a 3-year period, they ended up losing about 6.4 letters, and at a treatment frequency, the vast majority had 3 to 5 treatments a year. And in terms of breaking it down, basically 75% had 3 or more treatments, and about a third of patients had 0 to 2. What was interesting is after you got the implant, the average was not only a loss of vision, but a gain of 4.5 letters, with about 68% of people having 2 treatments or less, and that was the median number of treatments given. So we're able to get better letters with less treatment. And then how long did the treatment last? Well, essentially the median time for treatment, supplemental treatment was about 190 days. And essentially 25% of people were able to go 3 years without treatment. So it's really nice to know. And if you broke it down over time, it was interesting that essentially it was about 2 treatments a year averaging over the entire process. So people basically had 2 treatments, and usually they were mostly anti-VEGF rescues if they needed it. So it really showed the durability of this process, where before they treated with the implant, they needed 3.7 shots a year. In terms of CST, we had really good lowering of CST with significance at every single time point over the 36 months. And essentially, when we looked at area under the curve, the area under the curve in terms of microns was 336 microns over all the patients, which was significantly lower than it was before the implant, which was 371. So not only was it able to dry the retina, it was able to dry the retina for a longer period of time running forward. And then essentially, when we looked at intraocular pressure, the reality was the mean IOP remained stable. You didn't have a significant change in terms of pressure. When it was significant, it was about 2 millimeters of mercury. So it stayed stable over time. And then when we looked at the fact that what were the big things that we lose sleep over, you had about 25% of people at IOP over 25, about 11% of IOP over 30, and trabeculoplasty was performed 2% of the time, or 4 patients, and IOP surgery was only with 3%, of which 50% of those wasn't secondary to steroid-induced intraocular pressure, but due to the fact that they developed neovascular glaucoma. And 20% had IOP lowering medication. And this was about 50% less than the FAME trial. So understanding that the steroid challenge really worked very well. So, I mean, it really showed some really good data that if you treat these people with steroids, your chance of getting IOP-related complications is significantly reduced, as well as the fact that we're able to decrease the treatment burden in this hard-to-treat group of population.
What was the defined steroid challenge?
The defined steroid challenge depended on, some of them were given topical steroids, some of them were given Ozurdex, some of them were given triamcinolone. So it really was up to the investigator what they wanted to use.
And so what were the inclusion criteria based on the steroid challenge test?
The steroid challenge test where they couldn't have a significant rise in IOP after their steroid challenge. And that was, that is typically on label how the investigator decides if it's an increase that's clinically significant to the investigator. So all these people were enrolled when they felt like they didn't have a significant increase, but it wasn't spelled out, which actually wasn't like a number you had to get to.
So there's another trial coming up, the FAME, what is it called? The
New Day.
New Day. Tell us about the New Day trial.
So the New Day trial, so, we said with the Paladin trial, we saw some, obviously we saw a reversal. I mean, essentially you were losing 6 letters and now you're gaining 4. And this was a really well-treated group of patients. So again, because remember, a third of them had vision 20/40 or better and OCTs less than 300. So they had gone through a lot of anti-VEGF therapies. The question is the potential of getting really good vision better if you start with treatment-naive patients? Because even the FAME trial had previously treated patients. So if you're able to start with treatment-naive and compare it to aflibercept, what's the chance of you getting much better letters and how much rescue would you really need? And essentially the FAME trial basically showed us what can happen when to get the drug approved, but the New Day trial is going to basically look at around 360 patients, and what it's going to show, it's going to compare head-to-head to aflibercept, and the number of rescue injections is going to be the primary endpoint. It's going to be an 18-month trial. It's already enrolling, and it's basically 1-to-1 fluocinolone implant to aflibercept. So again, that trial will definitely have value because, steroid studies have been hampered because nobody wants to use steroid first line. So again, it'll be great to see what happens when you really give steroids a first line shot. Are they able to give you as much visual improvement as you get with anti-VEGFs? And are you able to get the treatment burden decreased enough so it really is palatable in this group of patients?
Well, the Paladin trial was impressive because really you decreased treatment burden and improve vision.
Yeah, it really was. I was really impressed looking at the data. There are going to be a lot of more subset analysis coming down, understanding that, the patient, looking at things like retinal thickness amplitude and looking at different IOP measurements. But the top line data really kind of makes us stop and think, because I spend a lot of time, as you know, giving CME events, and I talk about treatment burden. And we all know that real life trials, I call real life is messy because of the fact that, clinical trials giving monthly injections, you get the best vision, and then as you give both PRN or treat and extend, as you do that, you lose a little bit, but still relatively acceptable. But when you look at real life chart analyses, the vision goes down almost proportionally to the number of shots you give. Tom Chula has done some great work at showing this in AMD and DME. This, it really reverses your thought. This, I'm able to get better vision with less shots. So again, I think there's a real value for this in the DME population. And
there was always the threat of chronic glaucoma. This was the big threat, but doesn't seem to be the case.
No, I think it doesn't seem to be the case. And one of the interesting things, although we're talking about the Iluvien or Fluocinolone implant, I think in general, we're getting better at recognizing this. And I think what's really undervalued is the value of SLT in terms of lowering the pressure, because people who've had SLT, there were studies done a long time ago that really looked at triamcinolone. and this group out of Europe, and they treated half the people with SLT and half the people without, and then they gave them triamcinolone, and literally none of the people with the pre-treatment of SLT got IOP spikes. So I think SLT definitely has a place in this process. I know retina surgeons are obviously, it's not typically in their wheelhouse and they want to send it to their glaucoma specialist, but I think it's something to be looked at. And given the fact that, most of these IOPs, there's this whole thing called positive predictive value. What's the chance of you getting IOP rises? And this is a long calculation, but what it comes down to, the numbers are pretty impressive, because when it's all said and done, when you look at what's called the positive predictive value of getting an IOP, if you didn't have an IOP before the implant, you got about an 80% chance of not getting an IOP over 25. So again, you're right. We're getting better. We're getting better. We're understanding what's going on. And again, I think one of the problems is that retina specialists are so afraid of IOP elevations that they're not availing themselves of potential therapies that'll make both their lives and their patient lives better.
Yeah, that's a very good point. What was the percent of patients that needed to use topical glaucoma medications?
So the percentage of patients that needed to use topical glaucoma medicines were 20%. But again,
typically one or two agents.
Yeah, typically one or two agents. Very few people on 3 or more agents. And the interesting thing was, I told you about this concept, what's called positive predictive value. Not only when you use the drops, the interesting thing was they looked at the chance of you having IOP of 25 or greater at the end of the trial. It essentially said it was under 4%. So 3.1% of people had an IOP of 25 at the end of the trial. So to your point, using topical agents, the vast majority of patients were controlled with those drops and had normal IOP. And we've shown based on clinical work that I've done in the past, looking at other steroid implants, when you control the IOP, over time, if you compare it to the other eye, the retina nerve fiber layer doesn't seem to be more affected in the eye that had an IOP spike secondary to steroids.
So this is an evolving use of the fluocinolone implant. How do you think right now, in the absence of that head-to-head comparison with aflibercept, where does Iluvien fit into the treatment paradigm these days?
I think that basically, it goes through people who go through the dexamethasone implant. They do it a couple of times and they realize, look, this burden, you keep going up and down and up and down. I think that's, in my practice, it's about 2 or 3. And then I'm going to say, look, I'm at that point, my patients are complaining. How come I'm getting so many shots? How come I'm coming in so often? That's where I put the fluocinolone implant. I do believe that the more knowledge as I gain understanding this, it's definitely much earlier in my treatment paradigm. My treatment paradigm for anti-VEGF therapy based on the early trial has gone down. Now I'm 3 shots or less before I switch. I'm really big at looking at people at 2 weeks and trying to figure out, based on OCT, if the OCT, let's say I'm using bevacizumab, and the OCT shows, hey, look, it's 80% dry. It's VEGF mediated. I got the wrong anti-VEGF. Go to a branded agent. But if I'm on a branded agent and I'm less than 50%, I'm going to put a steroid in, because I think the 2 weeks is at the best you're going to get. And I really don't believe, based on the early trial, that people are going to change if they've gone 3 shots or more. So again, I've moved everything, shifted, to the left, for lack of a better word, to basically be much more critical of my therapies, having treated, thousands of diabetic patients. So that makes the fluocinolone implant much earlier in my treatment paradigm, which hopefully will give me better vision, because these retinas are not so chronic and the photoreceptors are still alive.
Lens status, do you prefer this in pseudophakic patients?
Yes, I do. My feeling about that is for all steroids, right? I don't think it's any more that it's going to be, typically when we give a fluocinolone implant, it's a phakic patient. I'm assuming that at 18 months, I'll be taking the cataract out. And again, I have this discussion with my patients, with my younger patients, and they make a decision. I've used it in patients who have been tired of having their blood sugar go up and down, understanding that they're going to be pseudophakic. But I will tell you, given the advances in cataract surgery, cataract surgery is the only advantage of getting older. Wisdom, I kind of think, is a little overrated, but for cataract surgery, you can be out of glasses your whole life. You spend them in it, you can be out of glasses, and multifocal lenses are a good option. Understanding that, yes, you may lose a little accommodation, but again, for this patient population who watch their vision yo-yo all the time and stop doing activities of daily living, I think it's really a good deal. I mean, I do believe that, it's something we discuss, and I say it's inevitability, but these patients are going to end up with cataract surgery earlier anyway, just due to the underlying diabetes.
Well, Michael, this has been a great discussion, I think, about a very exciting and evolving field. The Illuvian implant has certainly gone through a shifting position in the treatment paradigm. Wouldn't you say that?
Absolutely. I think, essentially, there were thoughts, we didn't really understand it when it came out. Now we're getting a better understanding that some patients do incredibly well. And these patients really, it's changed their life. I do think understanding, treating beforehand and looking at the fact that if you can do the steroid challenge and the steroid challenge does not raise the pressure, you can feel much more comfortable with the fact that it's unlikely to give you, glaucoma surgery for sure, or uncontrolled ocular hypertension with good medications. So again, and that, that's what really stopped everybody from using it. It's not that people don't believe in steroids. They're all scared about IOP. I mean, many years ago, I stood in front of subspecialty day and I asked everybody to raise their hands. What keeps you up at night? Is it the cataract or the IOP? And everybody said IOP. But the more that's demystified, I think the more it becomes a real value, because that's what everyone else is trying to do, right? Everyone's trying to get sustained release medications that do it over time. The implants are already there.
Yep. Well, good. Michael, thanks so much for your time.
Carmen, always thanks so much for having me. This is a great opportunity.